making of some of the bigger picture stuff that all hospital systems have to deal with. Main goals I've already outlined. We really want to understand what are we trying to do with this accreditation and the utilization of DNV and ISO. How does this help us create a system of management that is aligned with quality of care for patients? And how do these things affect us on the front lines? And in particular, how will you interact with DNV representatives as they come through our hospital system later this month? That's a lot to get through. And I'm going to race through some things. And again, this is a very high level thing. Many managers spend multiple days studying ISO 9001 to get a grasp for what it all means. I'm not going to be able to go into that level of detail, but I'm hoping to give everyone a general sense of what this is all about. And basically, Dr. Campbell would say our goal is to be a high reliability organization, which basically means even though we operate in an environment that is very challenging and full of many variables, we would have way fewer than our share of problems / accidents. In other words, harms that we might create in the context of attempting to deliver care. And we view risk very specifically. It is a probability. What is the chance this would happen? And then consequence. What are the consequences of the risk that we are entertaining? And if we can decrease the probability of an accident or a potential harm, then we can simply say that we are a low risk, but a high consequence, high value organization. And that alignment is really about a long-term, persistent focus. Defining high reliability healthcare is understanding that it's absolutely impossible in very dynamic settings like ours to have a rule for everything, to have a process that covers every contingency. We have to foster our own adaptive capacity to, without crossing major organizational lines of safety, lines of mutual respect, lines of basically the principles that we should hold dear, that we can manage those things and deliver high value care to patients. That's the general concept. Now, breaking that a little bit further from just a concept to a little bit more granular set of notions, this would encompass our ability to bring a culture together. In other words, how do we interact with each other? How do we interact with our roles, our responsibilities, our patients? Are we psychologically safe? Do we demonstrate accountability in the roles that we have? People can rely on us individually and as groups. Are we utilizing our teamwork and communications to our best effectiveness? How do we negotiate our roles in the context of the bigger picture? Are we holding ourselves to a standard of organizational excellence, or is this sort of a mixed bag? Leadership driving all of this, what does that mean? What are the characteristics of leadership that are required? And then, as we cannot possibly know everything that we're going to be dealing with, how do we learn? What are the elements that are necessary for us to be a continuously learning and adapting organization and teams and individuals? Transparency, what are we trying to achieve? How are we doing? Reliability, staying on that consistently and knowing that our partnerships are supporting it. Always using our measures and our improvement capabilities to get better. And then the notion of sharing what we're seeing with each other. Because learning doesn't happen across the whole space, it happens in pockets. How do we share all of that information that we may be gathering to benefit others who are similarly affected? Safety being the most basic and most important element of quality. Again, we work in a high risk, high consequence environment. We have to be thinking about all of the things that might happen to patients in our care that we would not want, that we'd want to prevent. And if you break down some of the underlying factors within our own organizations, within our teams, you can see the importance of those things that we talked about in the last slide in creating a culture of safety in a highly reliable system. So for example, failure to recognize or a lack of safety awareness, okay? Failure to communicate effectively within a team, failure to escalate or insufficient access to expertise, your own team culture, where people might, on the one hand, be isolated, or on the other hand, be accepted and supported. So all of these things can be integral to how we get to a point where someone unfortunately is harmed. And there's many, many others, but the notion is that there are ways to focus on these things as an organization that moves you forward. So how do we compare to other industries? In many industries who are trying to basically standardize their management approach, they want to know how are they conforming to the set of rules, the set of obligations that they have set out to utilize, to achieve in order to be highly reliable. And they will mention things like non-conformities. We are not conforming with our standard in this area. And you're going to start seeing non-conformity a lot around here. This is a word that is now in our eSafe system in terms of distribution of eSafes for further work. We find the area that is responsible or accountable for that non-conformity, and we rely on their expertise to help us understand how it occurred and what we might do to prevent it in the future. We are trying to overall not waste our resources by putting out fires, by constantly playing whack-a-mole with problems. We actually ultimately can harness a lot more of our energy and our creative capacity and our resources to deliver better healthcare while not creating an environment where we as healthcare providers feel so overwhelmed or don't feel valued. So the whole idea is it should come together as an overarching set of goals. Better care for patients in an environment that is really good for us as care providers. We do that through focusing on those harms. Again, safety focus. Can we reduce the infections that might be occurring as we try to do things to help patients? Foley catheters would be a good example. Reducing falls, reducing untimely documentation. In other words, delayed documentation, patient is continuing to get care, but the documentation of what others have done is not available to you. So you may not be working in the environment. You may not know what you need to know in order to provide good care, those types of things. So how do we approach that? Obviously, if we find problems, we want to have a standardized way of approaching that. That's where improvement science comes into play. So let's think about a nonconformity that might be very immediate to our everyday world. So one might be right now, our use of PPE. Where should we mask? Where shouldn't we mask? Where are those goggles important? Right now, you have in your inboxes an email that describes what Erlanger currently expects of us. But you may still be confused. You may not know clearly, well, does that mean over here I can or over there I shouldn't? So you may have to have more conversations locally within your clinical environments to understand what the rules of the game are. So this would be an opportunity to work together to understand what is needed to conform to the standard and then utilize that standard as well as promote it. So this is where the concepts of DNV and ISO come into play, right in our own backyard. We are one organization that is very diverse in terms of what it's trying to accomplish, the kinds of experts and personnel that are required to do it, all of the materials and everything else that are required. Very complex, but we are still one organization with one mission and one set of overarching goals. And our mission, compassionately caring for people, is an inward and outward thing. So one of the good things that you should know in terms of DNV and ISO 9001 is it is about both. It is about respecting one another and supporting one another as we work for our patients and our communities. So a big piece of this, as I'm harping on, is obviously the quality, safety, service, and the continuous improvement of those things. And the biggest differentiator probably of DNV as a partner in hospital accreditation and Joint Commission historically is DNV centers its entire business model on helping the organizations it works with to improve, give them clarity about where they're non-conforming and help them go forward rather than playing the gotcha game of you're not doing this, you're not doing that. Next time we come around, you better have it fixed. So they're a very active and continuous partner with respect to our ongoing improvement efforts. DNV stands for Det Norske Veritas, and I don't know if I'm pronouncing that correctly. This is a Norwegian company that's been around since the 1800s. However, in the recent time frame, it has become a deeming authority with CMS, Centers for Medicaid Services, Medicare Services, which is our major payer. And they are therefore responsible and accountable for deeming that we deserve accreditation. And that allows us to participate in Medicare. So there are other deeming authorities. DNV is one of the larger ones, as is Joint Commission. Again, their focus is on improving quality through risk mitigation, quality controls, and they utilize this ISO concept, which stands for International Organizational Standards. And I realize the initials are out of order with ISO, but iOS means something entirely different to most of us. So ISO is how that is said. What principles do they utilize? And this is not unique to quality management system from ISO. This is actually in other quality management systems. But the main thing is, what are you focused on? In the context of a healthcare organization, we're focused on the needs of our patients now and in the future. And in order to understand that, we have to really embrace strong interaction with them. We have to attract and retain our personnel, our expertise. We have to keep teams cohesive so they can continuously learn together and improve. And we definitely want to make sure that we are attracting and retaining our patients. So this is both us, our partnerships, our people, as well as the patients we serve, trying to really create an environment they're attracted to be here and they want to stay here and they want to continue to work with us over the long haul. In order to do that, you have to have a leadership that is driving that focus through the organization. In other words, clarifying that what we are about is that moment when we're seeing the patient. That's what we're about. Everything behind that really supports and makes that happen. So that unity of purpose, what do we need to do better over the next 2-3 years? And very specific planning on how we do that. Aligning through the organization from the C-suite all the way down to the front lines exactly what our target states are, but allowing through engagement adaptive adjustment, something that's specific to those clinical environments to meet those goals. It isn't a one-size-fits-all idea. You can't go to one clinic and say, this is how you're going to change for the better, and apply that same standard to another clinic that does an entirely different kind of work. That doesn't work out in the end. So focus is driven through the organization. How we do it at individual sites in the organization is an ongoing interaction between the people who do the work and the people who are trying to support that change. So that's the general concept of leadership. And that leads into the teaming, the importance of teaming. We can't do this just as a C-suite. We can't do this just as a part of the organization. We have to do it together, and we have to depend on each other's expertise. We have to think about, how is this change going to affect other people doing other kinds of work? How can we engage them in making this change work for all of us as we're trying to help patients? That whole general notion that we need to respect each other's positions, each other's authority, and each other's participation, basically how we all walk through this together. We want a management system that embraces that notion and would not ever violate that notion by creating sort of silos of thinking or silos of goals. Lastly, we don't want to just be winging it. We want to be utilizing expertise. That's part of the teaming, but we also need data. We need to be able to trend and measure the things that we're trying to change. And we need to use that information productively. We can't simply say, hey, we're not doing good enough in this. I expect you to do better. There's a lot more underneath that. You can't manage just by the ends and say, well, I expect you as the manager of this group to get better results. You have to say, what's going on? How is that? How are we getting these results? What are some of the things that we might do together that would improve those results? And you focus on the processes and the training and all the things that underlie that. So DNV, ISO 9001 are about supporting these principles as they engage with organizations. And I realize I'm starting to sound like a commercial. I don't mean to, but the general idea is that this should link everything together from a leadership perspective through the organization and how we approach improvement over time and what we care about. So this is a very busy slide that hopefully ties it all together in one big nutshell. Starting with those management principles, which I just described, there are ISO models. The 9000 model is aligned with basically industries and service organizations like ours, okay? Specifically 9001, which is the subset of sections that really help healthcare organizations, for example, to navigate how to approach doing all of this over time. So with that high level structure, which by the way, if you look at other ISO models, there's 14,000 models. There's multiple models out there that focus on different kinds of industries or different kinds of organizations. They all use the same language. They all use the same structures. So that's what that high level structure is about. You could go from one to the other and see a lot that looks alike, but they will have some specific differences depending on the industry they're in. There are some guidance around scope of services, around normative references. You don't want to compare healthcare to some other industry, terms and definitions so that no one gets lost. And then you get into the real meat and potatoes, which is you and your organization. Here are some tools to understand your own context, your regional context, the kinds of patients you serve, some of the economic realities, other factors that you have to understand in order to really know how to play your game. And then from that, you can also focus on what are the leadership activities that you're going to need to embrace. This is no longer conceptual. This is no longer principles. These are actual real world expectations for things that you must do as a leader in support of your organization. Planning, how do you go about that? What are the signals that you're doing it? What are you doing with it? You have to show a clear line of sight between an intention and an action and the effects of that action. And then there has to be learning. Did it have the effect you intended? What change needs to be made? All those planning elements have to be visible and apparent. Support and organization. This means we're process focused. We're not blaming people. We're saying, hey, things fall apart because we don't understand how to make it so it wouldn't. And we're going to figure that out. We're going to make sure that we're reliable, that we can actually achieve the goals we intend to achieve every time. And we're also thinking about systems. You can't just have a bunch of processes go in their own direction. Everything has to ultimately come together in effective, value-added patient care. And so a process by itself, even if it's performing well, may not be contributing to the overall goals of the organization. So getting everything to work together is a systems approach. So process approach and systems approach coming together. Those are the sections 7 and 8. And then performance evaluation. If you ain't measuring it, it don't matter. You have to be able to go inspect, see if it's doing what it should do, find those nonconformities, root them out, put them on display. We don't want anything swept under the rug anymore. We want to see those nonconformities so that we can manage them. So this is a really important thing of measurement systems. You have to be able to identify your nonconformities, hopefully before they create a harm. The whole notion is you're moving everything to the point of origin. Where do these defects start to happen? And then target that for improvement. Ultimately, you want to have the ability to improve. And that's where, again, the improvement science comes into play. All of this comes together in what we would call the Erlanger Health System Quality Management System. So ISO 9001:2015, the last revision, is really defined as an international standard to support how to create a quality management system. Okay. It's fairly generic, but it does align with healthcare organizations. It's formalized in that it's very specific in terms of the expectation of documenting your processes and procedures and responsibilities, and then following them in order to achieve the policies and goals of the organization. And then finally, it is a way of demonstrating that you are worthy of accreditation. So by conforming to these sets of goals and guidelines, you demonstrate your worthiness of accreditation year on year or for multiple year cycles. And the partnership with DNV is really to help us see our organization with a fresh lens, understand where we have gaps, and then work toward closing those gaps and demonstrate that continuous improvement, demonstrate that we're on the journey. And DNV, generally speaking, supports accreditation for organizations that are doing so. You don't have to be perfect to be accredited. You simply have to have enough of this built in to where you can see yourself and support your improvement journey. So in another way to put it, accreditation involves this ISO bucket, which is kind of the skeleton. It's sort of understanding who we are, what industry are in, what's our context, what we actually do, what are the services we deliver, what are the services we do not deliver, and being very specific about that. And then improving. Well, how do we do it? Are we having difficulty in terms of mitigating our risks? What are those risks? What are the sources of potential harm that we're talking about when we talk about those risks? How are we doing our planning around achieving these mission goals, achieving better quality care? And then, of course, all of the auditing, the measuring, the internal awareness of how we're doing day to day, week to week, month to month, and year on year. This and CMS regulations and other safety regulations all come together for hospital accreditation. So NIHO standards, which is basically the national framework for hospital accreditation that CMS supports. And there's also some fire safety, basically some chemical safety and that sort of stuff that we have to attend to. For doing our job as far as those things go, we can be an accredited hospital and we can therefore participate in CMS payment. So the different sections, I'm going to fly through this because I really think this is kind of getting in the weeds a little bit, but those sections of the ISO 9001 that relate to the development and stabilization and evolution of a quality management system are all baked into these 5 sections, okay? Starting with leadership. Leadership accountability. This is our management system. This is our quality management system. If it is not performing as it should, I am accountable as the leader, so to speak. Now, leadership doesn't just mean C-suite. It means any position you're in the organization that has a responsibility for that delivery system. So in effect, we are all leaders and we are all accountable for that. Customer focus. It ain't about me. Now, residents are in a very interesting position. Residents, fellows, you're in a position of being a customer yourself. You're trying to harness this period of time to develop into an independent provider of care, of healthcare. And your goals may be very specific to you. I want to be this kind of specialist. I want to work in this part of the country. I only want to do this kind of care. Whatever that may be, you're trying to utilize this experience toward those ends. So that makes you a customer as well, but you're not the ultimate customer. If it wasn't for the patients, there would be no need for you. And that's how you know you're not the ultimate customer. And so orienting to that, recognizing you're part of a bigger system and maintaining that customer focus is a big part of your leadership role too. Establish and communicate quality policy. Like PPE. What are our PPE rules right now? Those do change, but what are they now? Are we conforming? Are we promoting? Those are leadership roles. And then finally, OMC, overseeing the quality management system, the measures and the processes by which we know how we're doing and where our nonconformities lie. Planning. Again, if we're addressing those risks and opportunities, we need to be able to show that we're doing it, how we're doing it, and what it's resulting in. Knowing the strategic objectives. Do you know the strategic objectives of Erlanger Health System? Sometimes it's a little hard to know. And this, again, falls back on what DNV is looking for. If DNV sees that the organization hasn't conveyed these mission goals particularly well, then they're going to say so. And they're going to ask, what might you be able to do to fix that? How can you make it clear to everybody who works here what our strategic objectives are? And then understanding that plans are important, but all plans fail. You have to be able to adapt. You have to be able to make changes and adjust so that you can achieve those goals under changing circumstances, or as you learn more about the barriers or challenges that are in play. Support. If everything is focused on patient care and patient support, or supporting the mission of care delivery, then you have to put a lot of your emphasis on the environments in which that care is happening, right? Where are those transactions occurring? And so the ability to provide the necessary people, infrastructure, environments for that care is part of the DNV review process. And that will come into play later in the month as they're walking through our clinics and our units and talking to us individually. One of the things they're looking for is our capability to support that care. And they're not here for gotchas. They just want to help us see where we might have opportunities to get better. Measurements, again, walking through these spaces. Do you see how you're doing? Are there ways to know how you're doing? Are those measures visible? Are you utilizing them? Organizational knowledge and competencies. Do you feel comfortable doing your job? Do you feel like you have the training to do your job? Those types of things are very important. And then documentation. Everything we do, especially everything we do with and to a patient, has to be pretty clear in a record so that we can know down the road whether or not we're doing the right things or how that builds over time toward goals. So documentation, timely documentation is a big piece. Operations. Thinking about operations from the perspective of both processes and systems. What are the products needed? Again, this is all baking back into that support of the healthcare delivery system and the people who do it. If you're process focused, then you know the gap is, say, a training issue, then you focus on the process of training. So all of that focus helps to keep us from blaming one another when things don't go well and makes this a productive endeavor. Performance evaluation, again, looking inward. How are we doing? What are the measures that show how we're doing? How are we using those measures to identify where we need to prioritize some resources or prioritize some effort and time? This also is an interactive thing in terms of leadership development or people development. Those management reviews, what are your strengths? What are some of your challenges? What are some things that we could work on together? Can we do some goal setting together? All of that comes into this overall structure that DNV is looking through under the ISO 9001 framework. And then improvement. Having the leadership piece and the focus piece and utilizing all of those other elements, including ongoing measurement. What are we prioritizing for improvement? How do we understand what the causes of those difficulties are? And then how do we actually target those things for improvement that is sustained? And we're not talking about whack-a-mole anymore. We're talking about really understanding why things happen, fundamentally changing them so that the outcome is reliably different, ideally better. So that's wherein all of this should come together in a continuous model that we would call a quality management system. The engine is somewhat complex, but it has all those elements in it. There's a lot of inputs, and right at the top is voice of customer. What do patients expect? How do they define value? And then there's a lot of other things that fall into that. local priorities in terms of measurable gaps, other factors that all flow into the idea of what we're working on. And this is a bit of a kind of a PDSA sort of thing over here, where you basically have planning, you've got interaction and support, you've got a measurement system, and then you're basically hardwiring things and understanding what to work on next. So this is a very circular model in terms of how the system operates. And you see that leadership interacts with all of them. And hopefully now, based on some things I described, that makes sense. And then of course, there's the outputs. These are sort of the things that people like to manage. They want to manage the output. Like I said before, hey, manager, you're not hitting the number over here. You need to go fix that. That sort of expectation. That's not allowed in this system. If your outputs aren't what you want them to be, you have to go into the processes that are creating those outputs. And you have to work on those together. That's where that teaming concept comes into play. So all of these things are really, really relevant to our organization's health. How do patients look at us? If we were to put it all together, what are the quality of our outcomes compared to others? How many harms do we create or prevent? Our compliance, of course. Our satisfaction of our own partners in healthcare and their retention over time so that we can grow together. And then, of course, there has to be some sustainability, right? There has to be some financial strength that comes with all of this. So in a nutshell, organizations that don't have a quality management system look very much like this. It's basically everyone's working in their own purpose. And they all care about their own purpose, but it's not working very well together. Gradually harnessing all of that into a direction that's still somewhat wasteful because there's probably a lot of overlapping efforts. And then starting to get these efforts to work together a little bit more so that they're very aligned, at least in terms of direction, you're not creating wastes. Ultimately, everything is integrated so you're not necessarily having, you don't have unnecessary redundancies in efforts. You can work together in broader partnerships toward shared goals. So that's kind of the nutshell of what's trying to be accomplished at an organizational level. And again, what's the output direction? Patient care, high value patient care, and supporting people to get there. At a very granular level, if you're a manager or if you have responsibility over a cohort of people, you may be familiar with the notion of firefighting. Basically, a problem pops up, you tackle that problem, next problem, next problem, next problem, but there's no learning that's happening, and you see the same problem over and over again. Well, where there's a lot of those, you may want to have more firefighters. So one of the earlier things you might do is create more capacity to do the same thing. But ultimately, what you're trying to do is get to the point where you can see where the fires tend to break out and start to create countermeasures that are focused on those areas. You want to basically have the capability to respond way before the fire, get signals that a fire might break out. So that's an early detection. In our safety culture, that would be near misses, serious safety events 1 through 3, basically the things that didn't reach the patient. But our signals that in our system, we have a vulnerability, that a non-conformity that could create a situation where a patient's hurt. You want to be working in that direction. And ultimately, you want to be preventing all those things at the source. You want to prevent all those non-conformities from happening in the first place. And you can see that's where a lot of process focus is required. You can't blame anybody anymore. You have to do the work and find the root causes, and you have to sort it out. So walking through this journey is basically what we're doing. And that's what our accreditation is about. Accreditation doesn't mean we're here. It means we're making progress across here. Okay. So all of this to say, we're going to have a site visit later this month. Right now, DNV is in the house, but DNV is working with our leadership right now. Those earlier components of leadership modeling, leadership requirements, That is getting evaluated right now. And there's a lot of feedback going on, I'm sure. And there'll be a report out, and there'll be some expectations for things going forward and some plans on how to go there. But later in the month, a larger team's going to be here going into our actual clinical environments. Okay. And they're going to be potentially visiting with you as residents or fellows or faculty. And you guys might want to have a general sense of what to expect with that. And so one of the things that I wanted to try to do today is share some information that we've been receiving in Leadership Forum about how we can support our people as DNV's coming through. So this is a recurring sort of event. There's nothing crazy or unusual about this. We're not being singled out in any way. DNV has a regular cycle, and we are in this sort of phase over here, this sort of year 3-4 range of where we are. And they're going to be bringing people who have clinical expertise in our field. We're going to have people who are sort of generalists in terms of healthcare systems, and there's going to be other specialties represented. They're going to be looking for specific kinds of systems, if you will, within our organization. And then they're going to be basically aware of what we say our mission is, what we say our values are. They're going to be looking at and asking us about our patient care processes. They're going to be looking at our environments of care, EOC. They're going to be looking at a lot of data. In other words, what are the measures of what we say we do? And they're going to be, again, they're trying to give us an outside, fresh eyes view on how our organization is doing without gotchas. It's just trying to bring clarity, help us bring clarity to the things we need to focus on. In effect, they want to know, do we document what we do? Do we do what we document? And this is sort of the interaction between policies and job, descriptions and the actual efforts. Can we show that we're doing it? Can we connect the dots through data? And then are we showing signals that where we have gaps, we're improving it? So if we're doing these things, guess what we are? A learning organization that is absolutely aligned with ISO 9001 structures and DNV partnership in terms of hospital accreditation. And presumably, if we keep at it, we're going to get better and better and better and better and better. We are accredited. We're accredited also as a critical access hospital. And we have a number of service lines that are also accredited for their own efforts. And over time, these bottom certifications may grow and grow and grow. We may have more and more and more of them as we seek them out. But what's happening this month is part of our natural accreditation cycle. So what are some things that you guys might want to at least be aware of coming into this? Say exactly what you do. To the best of your knowledge, if someone asks you about a policy in your work area, answer them. Or say, I don't know, if you don't know. That's okay. What procedures are you using? What plans or guidelines are you using? Just share. Just share exactly what you're aware of or what you know or what you're relying on. As far as a surveyor sort of watching you work, just do your work. Just do your work as you normally would. If they ask you to show the process, say, okay, yeah, this is what I'm doing. This is how I'm doing it. And this is why. Prove it. If you have a situation where in your clinical environment, there's some measures that you do rely on or reference, you can say, and here's some of the things we're working on. If you don't, you don't. Don't make anything up. Just be yourself and be honest. Okay. The professionalism piece of this is you may be, let's say you've not had a great day. Let's say right now you might have a little bit of a chip on your shoulder, or you might have a little bit of a grudge, or you might have, something that's a bit of a negative baggage. Not letting that taint your responses. That's an important thing. Being honest, hey, I had a little bit of a frustration today. This didn't work. That's fine. This organization is stupid. It never helps me. That's not fine. That's where the professionalism piece there's a space there, right? It's okay to say we've got gaps, but you're not attacking your organization. You're not attacking your fellow workers. That's a key thing. And then, basically, if there's activities that are ongoing, or if you're part of an improvement action and you're asked about it, just share that story too. Again, just know the mission. What is our mission? We compassionately care for people. That has a huge bandwidth to it, but that's our mission. It isn't just care for people who are sick. We care for all of our patients, and we also care for each other. So if you know that, you're way ahead of the game. This compliance with our current PPE thing is probably going to be a focus area, you could imagine. So make sure you are aware of these requirements. And if you see someone who is not conforming, remind them, support them in improving that, but set the expectation. If you tolerate it, you're supporting it. So be very clear about that. Always be polite, be respectful, be courteous. If you don't have time, just say so. I'm sorry, I'd love to spend some time with you, but actually I need to go do this right now. That's perfectly fine, okay? Oftentimes these folks aren't gonna be very invasive and they're not gonna demand much of you. But if they do involve you in their discussions, or if they bring something up, be the same kind person you always are. This environments of care stuff, if your workspaces, and I mean your public workspaces, look cluttered and messy, do your part. Help clean it up, help make it look a little bit more professional. They're not going to come into your private workspaces. Okay, so in pediatrics, we have the aquarium, which is a bunch of computers in a room behind a door, and there's going to be cups, there's going to be bottles, there's going to be clutter, because that's kind of your den, and that's perfectly fine. They're not going to be coming in there and judging you on that. But in the environments that are interfacing with patients, with customers, that are professional, that have a professional standard, if you see those spaces looking a little bit, say, less than presentable, it's safe to bring it up. And it's really awesome to support an effort to get it cleaned up. That first impression rule, right? Always to the best of your ability. And then again, if you know your role in emergency situations, if someone, had, those little code things on your badge buddies, they may ask you, say, hey, a code blah was just called. What are you supposed to do? Not a bad time to think about that. Just kind of peruse those little code things that you have on your badge buddy to understand what these codes are, and in general, what you're supposed to do. And then some of this other stuff is really more into the weeds of various roles and responsibilities. I don't want to overwhelm you. So one of the things they may ask you about is documentation, okay, and your process of documentation. For physicians, that's probably a relatively big one. So just, again, be honest. This is what we do. This is where we are. Are there problems? Are you running behind on your discharge summaries? Whatever. It's okay to say so. And to best of your understanding, explain what's going on to try and improve that. Restraint's not a big player in pediatrics, but certainly a big player elsewhere, and that can be an area of focus. So understanding your restraints policy and your ongoing review and renewal process will be very important. And as far as interpreters go, it's a really important thing to note in your documentation if an interpreter was utilized and what language was utilized. That helps to ensure that we are in fact meeting that focus element in our principles, that we are actually very, very intent on partnering with our families. And then there's some other stuff that'll probably land more into nursing and other domains. So that's all I had to share today. If you guys are in on Zoom and you haven't already signed in or done your QR code to get credit, you notice I'm putting this at the back end, because if you bailed out, on you. So go ahead and sign in through the chat box, tell us your name and department, or you can use the QR code that was on the announcement for this talk, and you can get credit for today's event. This is a requirement of the residency and fellowships that everyone sees this, whether they do it now or they see it later, but make sure you get credit for that so that no one comes hounding you. Folks that really should be doing this talk instead of me are listed here because they're really the true organizational experts in DNV, ISO, and all the other jargony stuff that you see bannered around here. But Dr. Campbell graciously gave me the bulk of these slides that I could then sort of mash together into some sort of a talk. So I hope this has been useful to you guys. I want to thank you all for being part of our Erlanger Health System and also being part of our educational and learning engine with our partnership with UT College of Medicine. Every one of you is a leader. Every one of you has major important accountabilities, and you have a lot of value in terms of meeting our mission goals in compassionately caring for people, including yourselves and your teammates. So again, thank you very much for your time today. And if you have any questions, feel free to either chat them through or you can speak up and I'll do my best.
Thank you. Thank you. Yes, a round of applause.
Okay. All right. Thanks, guys. See ya. What did you think off the cuff?
I thought it was really insightful and like, especially for selfishly someone like me and my